I have a couple of little housekeeping items. Our next and last speaker is Dr. Aaminah Azhar, and she is actually one of our own residents, a first-year resident here in our department. She's been taking notes feverishly and wants to give a wrap-up of what's happened this whole entire day. Few quick bullet points of each speaker's presentation, including the panel discussion of what she's gained, and would like to share that with our audience so that you can have some takeaway points before we leave. And for you to know, she completed her medical school at Texas A&M and plans to pursue a fellowship training in dermatopathology. All right. Aaminah?
Hi, thank you, Dr. Allen. So yeah, I'll be sharing the wrap up. We had a great day with amazing talks. So thank you to all of our panelists and presenters who made this possible. There were so many good things today that couldn't even pick which ones to put. So we'll go through. First, art and medicine. At first, we talked about looking at the patient as a whole picture and determining their story before making the diagnosis. Kind of using the tools in art, like the close look skill and visual training in the arts, that can help us improve our observational skills in dermatology and especially in skin of color. Dr. McKinley Grant talked about the red and gray color wheels and how they can help make a differential diagnosis in skin of color patients and help us identify these life-threatening conditions like erythema, pallor, and cyanosis. Recognizing red, so looking for those shades of red can reflect the process, whether that's inflammatory or infectious, malignant, or granulomatous. And recognizing gray and blue hues in skin of color can help us look for decreased oxygen concentration, decreased hemoglobin, necrosis, and things like sepsis, anemia, and cyanosis. Dr. Adatama talked about scarring alopecia and skin of color. So for CCCA, you look for women with African ancestry who have decreased hair density along the vertex and frontal scalp. There are two different variants as shown. They can have a family history of hair loss that can be autosomal dominant. And they may also have uterine fibroids. Hair breakage is an early sign without any scarring features like he was talking about, and they can endorse pruritus and scalp tenderness. Dermoscopy and trichoscopy and histopath can be really helpful in diagnosis. He specifically mentioned peripilar white-gray halos as shown here that can be 100% specific. And he also mentioned that histopathology can be consistent with CCCA, even if we don't see clinically evident disease. So he was saying it may be important to expand our treatments to all of those areas. There were some recent advancements he talks about, like metformin could help with the fibrotic process. There was hair growth in 2 patients with recalcitrant CCCA. Platelet-rich plasma was shown to help in a case series of 5 patients. Treatment of seborrheic dermatitis, because this is the most common concurrent hair disorder in patients with CCCA. This may help with the inflammation. And then, of course, JAK inhibitors are the new biggest thing. And there was some evidence to show activation of the JAK-STAT pathway in CCCA biopsies. Frontal fibrosing alopecia presents like this, like a symmetric band-like zone of scarring. It can happen in skin of color patients, but mostly in Caucasian women, possibly associated with contact allergens, so you can consider patch testing these patients. He noticed in his cohort that lichen planus pigmentosus was more common in Black women with frontal fibrosing alopecia versus Caucasian women, along with a younger age of presentation and itch. And he also introduced us to fibrosing alopecia and a pattern distribution that can actually look very similar to androgenetic alopecia. And you can consider a biopsy when trichoscopy or dermoscopy shows you those peripilar white halos and casts. And this can be important because anti-inflammatories can help them. Traction alopecia is initially non-scarring, but chronic forms can convert into a scarring form of alopecia. A positive fringe sign is sensitive and specific, and natural hairstyles and loose hairstyles and wigs are associated with the least risk of traction alopecia. He talked about using ILK, minoxidil, topical minoxidil, and low-dose minoxidil for treatment of traction alopecia. Dr. Pasligua talked about Native Americans and Hispanics and dermatoses in these populations. And so inflammatory disorders in these populations, it can be a little harder to appreciate erythema and erythroderma. Natives actually have a higher rate of superficial bacterial infection and atopic dermatitis. They have a higher incidence of contact dermatitis and a lower prevalence of psoriasis, but it can be more severe. African American patients are at higher risk of severe drug eruptions. Cutaneous malignancies, there of course is a lower incidence, but a greater morbidity and mortality in these populations, along with melanoma having an increased mortality. Actually, natives have the second highest melanoma mortality rate after Caucasians, and mycosis fungoides is more common in African American patients, but it has a worse prognosis and higher mortality. So these are some of the conditions that we talked about that are more common in these populations. We touched on the fact that nodulous cystic acne can be more severe and put patients at higher risk of scarring. And so it's important to initiate aggressive therapies early. But actinic prurigo is a photodermatitis that's common in this population. And pemphigus vulgaris is actually in Hispanics in New Mexico is 4 times higher in prevalence than non-Hispanics. And xeroderma pigmentosum is actually a lot more common in the Navajo Nation as compared to the rest of the population. So we talked about some cultural beliefs as well. These Native American populations can have a good connection with traditional healers, and we have to take that into consideration when treating. And hair is a really important part of their identity. It can even represent a sacred connection to a family, tribe, and loss of it can have a really detrimental impact on their quality of life. Hispanics commonly have multi-generational households, which means more people may be involved in their care, and men and women may have gender-specific roles when it comes to accessing healthcare. And so we talked about photoprotection strategies. And compared to white counterparts, skin of color patients are less likely to use sunscreen. We talked about because there is a perception that melanin can help protect you and you don't need sunscreen. And so that just shows that we need to be educating even more. And we all know that solar radiation and UV light can induce photoaging and carcinogenesis. But we also learned a lot about how visible light can actually generate oxidative stress as well. And more about visible light, it can induce inflammation and pigmentation, especially in patients with darker skin tones. She also showed us this slide talking about how iron oxide containing formulations of sunscreen can actually protect against visible light and reduce pigmentation. And that's a big deal for our patients with darker skin tones. And that takes us into Dr. Vashi's talk about treating hyperpigmentation in skin of color. So we talked about hydroquinone, and that is gold standard for treating hyperpigmentation. It inhibits tyrosinase, but it's not available over the counter as of 2020, as of the 2020 CARES Act. And so she talked about how patients using a compounding cream, a prescription compounding cream, actually have more improvement than with hydroquinone monotherapy. It should be safe to use for about 6 months. Chemical peels can enhance epidermal turnover. You can pre-treat patients with hydroquinone, stop the retinoids a few days prior. They are safe in darker skin tones, and in Dr. Vashi's cohort, 73% of patients improved. Microneedling can improve scars and wrinkling. This pigmentation is rarely seen when sun protective measures are taken. It also can be very effective in recalcitrant melasma. And lasers were unpredictable. They did lead to some good response, but also hypo and hyperpigmentation. Non-ablative fractionated lasers may be better for skin of color, but she recommended always performing a test spot maybe using longer wavelengths, adequate cooling between pulses, aggressive sun protection, and topical steroids. Melasma, she showed using a Woods lamp to look for subclinical melasma. Stopping the contraceptive won't reverse the pigment change, but can prevent more. And she talked about oral tranexamic acid. It's shown to be safe, but it's really important to take a good clinical history as well. Exogenous ochronosis, these were just some photos to help us recognize it with the red, brown hue or blue, gray hue. It's difficult to treat, but of course, stop the hydroquinone. And these are two examples of exogenous ochronosis that she showed that were treated with lasers. Finally, she reviewed some therapies for vitiligo. She showed an example of depigmentation that may be helpful in lighter skin types. And we've all heard of the topical JAK inhibitors and use of off-label oral JAK inhibitors for vitiligo. For DPNs, she showed her low-level cautery treatment protocol. So she talked about using a test spot and very low level, buzzing the surface, and then removing any debris with the dry gauze. And then, of course, our hair care panel, which was amazing. So thank you to all of our panelists. But we learned that culturally competent hair care can build pride and confidence in children with textured hair. Just like the story of the young child Z, who was a lot more confident after that. And teachers can serve as surrogate caregivers, and thank you to our teachers who are able to help with that. Hair care professionals play a role. It's important to know about the salons that can help in your area. There are resources available, like we heard of, like the Hair Initiative, Cut It Forward, and we heard about some resources online. And finally, we need to produce healthcare professionals that can address these hair care needs in children with textured hair to help care for them with their adopted parents or foster parents or blood caregivers. Thank you so much.
Excellent. Thank you. Thank you. I have two last slides and then we will be done, but these are just as a reminder. Yes. Okay. One moment. Let me get that together. I think this will do it. I want to first, yes. Thank you for everyone who has been with us to the very end of the Mark Allen Everett Skin of Color Symposium. Not only thanking our speakers that were just wonderful. I've already received multiple texts from audience talking about how just outstanding it's been, but also let me get it going here to talk about the panelists as well, the planning committee, all the residents behind the scenes who've been working the chat and the housekeeping functions and just manning everything for us. We thank you, and all of our sponsors, both Doctors Richard Van Horn and Dr. Betty Pfefferbaum and Dr. Rose Pfefferbaum. We appreciate them. In addition to our namesake, Dr. Mark Allen Everett and the Everett Family Affiliated Fund for their continued significant support for our symposium. And I want to thank you, the audience, for staying with us, and hopefully that you've been enriched throughout the day, and will tell others about our symposium. And be sure and save the date. Next year, it will be Friday, May 10th of next year, 2024. So that is the second Friday of May of next year. So we want everyone to put that on the calendar and be ready to register when we send it out in November, and not wait till the last minute, so that we can get everybody on the symposium. So with that, I will stop sharing and thank you all for a wonderful day today, and we'll see you next year. Thank you.